Welcome and thank you for joining us today for this seminar, 10 Years of Implementation Outcome Research, a Snapshot of Progress and Future Directions. This is the first event of the 2023 Institute for Implementation Science Seminar Series, which features lectures with leading implementation science experts. We have a few quick announcements before we get started. This seminar is being recorded and the recording will be posted on our website after the event. All microphones are muted. So if you have any questions or comments during the seminar, please enter them into the Q&A box as there will be time for questions after the presentation. CHEST continuing education credits are available for attending this seminar, and details on how to receive credits will be emailed after the event. I'll now hand it over to our Institute co-director, Dr. Maria Fernandez, for opening remarks. Thank you.
Thank you, Ricky. And thank you and welcome everyone to our third annual workshop and seminar series. I'm Maria Fernandez. I'm the Vice President of Population Health and Implementation Science at UT Health Houston and the co-director of our Institute for Implementation Science, along with Dr. Bijal Balasubramanian, who you'll be hearing from in just a moment to introduce our speaker. As you can see, we have an amazing lineup of some of the leaders in the field of implementation science, and we hope that you will join us for our other talks as well. Turning it over to you, Bijal.
Thank you, Maria. It is my pleasure to introduce Dr. Enola Proctor for this first of an amazing series of presentations on implementation science. Dr. Proctor is Shanti K. Kinduka Distinguished Professor Emeritus, Brown School of Institute for Public Health, Brown School and Institute for Public Health at Washington University in St. Louis. Her work advances the field of dissemination and implementation science, leading teams to distinguish, clearly define, develop taxonomies, and advance the conceptual, linguistic, and methodological clarity in the field. Her current projects address implementation outcomes, which she's going to speak on, speed of implementation, and building the implementation science research workforce. She directs the Implementation Research Institute, which is a training program in implementation science funded by the National Institute for Mental Health. And she has advised the WHO on implementation science projects in low and middle income countries, including work on COVID vaccine implementation and accelerating response to public health emergencies. Thank you, Dr. Proctor, for your work, as well as for taking the time today to talk about 10 years of implementation outcomes research. And I will hand it over to you from here.
Thank you. I'm really delighted to be with you today and very thrilled to be kicking off your series, which has such outstanding speakers. So thanks for joining us today. I look forward to your questions and to opportunity to discuss this work after my presentation. So let's see, I want to be sure my screen, I'm not seeing my slides. Ricky, am I managing my slides now?
Yes, you can go ahead and share.
Okay. Sorry, we had it all up. Now we're in good shape. Okay. So I really welcome the opportunity to do some reflection, and I want to take you on a little journey with me from how we started to think about implementation outcomes in probably the year 2010, 2011, and revisit some of the key points of that paper. Then reflect with you on what happened in the field over the last 10 years with respect to implementation outcomes. Share with you some findings from our review of the state of implementation outcomes research now, 10 years later, and then offer some projections for where I think we need to go with our conceptualization and our research on this topic. So how did we start thinking about implementation outcomes? Well, I was newly launching a CTSA core in dissemination and implementation research, and deliberately positioned that core as a research methodology core, whose purpose was to work with investigators to help facilitate the success of their grants. And I thought, you know, if I'm going to help other people write grants, I really personally, and I think the field needs more clarity on how we can evaluate the success of implementation. And of course, the prevailing view was that we had an empirically supported treatment or a quality improvement that was expected to produce clinical outcomes for individuals and hopefully for community health as well. So the usual paradigm was testing the effectiveness of an intervention. However, we knew that interventions don't magically implement themselves, no matter how strong their evidence, no matter how much we want them to be adopted, rather that we need some change strategies to help put them into place. So we wrote a paper in 2009 distinguishing between and calling attention to two kinds of intervention: the empirically supported treatment, or as our friend Jeff Curran characterizes it, the what, and the implementation strategy as an intervention that really guides us to how we put that empirically supported treatment into practice. Similarly, we advocated the need to look at multiple kinds of outcomes: implementation outcomes, service system outcomes as identified by the Institute of Medicine, and then the kind of clinical and health related outcomes that we expected these outcomes to help achieve. So the core of implementation science we proposed in 2009 was really a focus on implementation strategies, implementation outcomes, and their effects on service outcomes. So we published a paper in 2011 with this terrific team of co-authors and proposed a taxonomy of 8 implementation outcomes. And we defined implementation outcomes as the effect of deliberate and purposive actions to implement new treatments, practices, and services. And you may recognize those deliberate and purposive actions as implementation strategies. But a key point in this definition is that we need to do something to achieve implementation outcomes. Hence, we call them outcomes. Now, what is the role of implementation outcomes? As indicated in the previous slide, they are the most proximal indicators of implementation processes. They are indicators of whether the thing got put into place and was accepted, adopted, deemed appropriate, cost possible, feasible, delivered with fidelity, and penetrating enough of the service delivery within a system that we can expect to achieve subsequent outcomes, and finally, sustainability. So their role was never intended to be the end all, but rather proximal indicators of the implementation processes and intermediate outcomes in relation to subsequent and different types of outcomes. So again, to reiterate, we proposed that implementation outcomes should be understood and investigated for their own attainment, but also for their role in achieving such service outcomes as efficiency of delivery, safety of interventions, the effectiveness, the equity, the patient-centeredness, and the timeliness of care. And it's only when we achieve these kinds of outcomes in our service delivery systems that we can expect to positively impact patient health and public health improvements. So our key points in the 2011 paper were that implementation outcomes are achieved by implementation strategies, and they have subsequent effects. Now, why were these distinctions important? People were busy measuring distal or ultimate outcomes of interventions to see if they really helped people achieve the improvements in health functioning, clinical indicators, and satisfaction with the healthcare. However, it's wholly possible to have an effective intervention when potential users never know about it, or they're poorly understood and therefore poorly delivered, that they have poor reach in the health systems where we expect them to work their magic or have their positive effects. They can be implemented but with poor delivery, or they can be implemented and not sustained. And therefore, it's really critical that we take a look at implementation outcomes. So what we had proposed is that the field, and remember, this taxonomy was developed through a literature review where we collected many examples of studies of implementing empirically supported treatment, and we analyzed how they were being evaluated. We found, in short, a mess. We found inconsistent terminology. We found often a scale would be labeled, say, acceptability, but it really measured nothing about attitudes or behaviors. It looked at delivery. So there was quite a bit of blurring and lack of distinctiveness between the concepts. So we urged that people offer conceptual and operational definitions in their work, that they use consistent terminology, both internally, internal validity or consistency, and also that they use terms that were being used widely in the literature to enable us to do reviews and to find studies that also looked at these same outcomes. And so far as the language was different, then we would be unable to build on each other's research and accrue a body of knowledge. We also advocated theory building. We urged investigators to specify their hypotheses about the mechanisms and processes of change and how outcomes would be achieved and what the effect of these implementation outcomes might be on other outcomes. We also encouraged more robust measurement because we lacked at that time psychometrically tested measures, particularly through quantitative methods of data collection for capturing implementation outcomes. So it's interesting, when we finished our drafts of the 2011 paper, I actually said in one of our team meetings, you know, I'm not sure that we've really accomplished anything. We've reviewed the literature, we've tried to clean up some conceptualizations, but mostly we've identified some challenges and some problems. Should we publish this? And fortunately, our team members said, we'd spent 18 months immersed in the literature. We think we've offered something that could be of help to others, so let's get it out there. So we did. So what happened? Well, first of all, we were surprised. We were surprised and gifted by so many developments in the field. The field really did respond. There have been many advances in conceptualization. Distinctions have been sharpened, for instance, between anticipated implementation outcomes and actually achieved implementation outcomes. There have been conceptual distinctions offered between perceptual and behavioral indicators of implementation outcomes. There's been work linking the taxonomy of these 8 implementation outcomes to the CFR model. So quite a bit of advances are evident in the literature. We also saw a number of measurement advances. There have been a number of review papers evaluating the psychometric properties and providing us with some guidance about which measures are strongest. The CIRC Instrument Review Project developed a resource, an online resource organized around our taxonomy. And the program announcements at the NIH for the dissemination and implementation research in health began to call for measurement of implementation outcomes. So I'm just going to share a few of these. You'll have access to the slides later, I believe. There are a number of very helpful methodology papers tackling the very challenges in measurement that we encountered and called up and offering us some direction. So we're very, very grateful for this work that has helped propel the field forward. So where are we now? And the impetus for this paper was actually a conversation with Rebecca Langnick Hall, another of the authors on our 2023 paper, who said, I wonder what has happened in the 10 years since we not only provided a taxonomy, but more importantly, called for developments in the field to help refine the conceptualization, measurement, and building an empirical body of evidence. So we undertook a 10-year scoping review of literature around implementation outcomes. And we did a forward citation tracing using 2 different search strategies. We felt it would be unfair. We know there's a lot of work on implementation outcomes not captured in our scoping review, because one of our selection criteria was that the papers included in our review would have cited the 2011 paper. Now, why is this? Not just because I wanted to see who had cited me, but because we thought it was unfair to examine articles that were unaware of the 2011 paper, to examine those articles to see if they addressed the challenges we put forth in that paper around the conceptual and research agenda for future work. We also used a selection criteria that we wanted only empirical work that had been peer reviewed and that measured or assessed at least one implementation outcomes. And this shows our flow diagram of 1,346 records. We ended up with 400 records that we did review very thoroughly for this scoping review. So a snapshot of the research. First of all, we found international studies as well as US studies, a lot of varied funders, including the National Institutes of Health, but also government funders in other countries and regions of the world. 45.8% of them focused on physical health care. Behavioral health care was the second largest category, but also schools, social service agencies, a number of settings had evaluated implementation outcomes. We found that 40% were testing the implementation of one singular evidence-based practice. And we found that 2/3 were observational studies. In other words, they measured implementation outcomes, but did not do much analytic work. And I'll describe some details about that later. So what outcomes were investigated in our 400 article sample? Well, first of all, acceptability was the predominant one, as has been found in other reports of implementation outcomes. Also, feasibility and fidelity have been examined a great deal. The other outcomes have received less attention over time. We did find, and we had hypothesized in the 2011 paper, that different outcomes likely would be and probably should be differentially salient for different phases of the implementation process. In other words, we conjectured that in the exploration phase, outcomes such as appropriateness, feasibility, and acceptability would be explored. And indeed, that is what we found in our empirical review in 2023. We found that in the preparation phase, the implementation outcomes most likely to be addressed were adoption, cost, and feasibility. And not surprisingly, in the sustainment phase, sustainability was the outcome that received most attention. And this, of course, was limited to the studies that indicated in their methodology or their study description the phases of implementation in which the project was collected. Now, recall that one of the critical challenges raised in our 2011 paper was that we engage in theory building. And as you all know, theory building, theory testing, and building evidence requires that we look at two or more concepts in relation to one another. These bar charts show the proportion of articles by each implementation outcome that employed descriptive, correlational analyses, or in which the implementation outcome served as the independent variable in relation to service system or clinical outcomes. And finally, the purple bar indicates the proportion of research around each implementation outcome that treated the implementation outcome as a dependent variable to be achieved. In other words, they said, how do we achieve acceptability? How do we achieve feasibility? How do we achieve fidelity? So one of our critical codes for the scoping review was to capture the role in analysis and the kind of analytic approach that the study employed. So recall also that one of our central messages in the 2011 paper was an advocacy of harmonization of language. We were quite concerned that if people constantly invented a new term or used a term inconsistently in conceptualizing and actually measuring the outcome, this would slow our accrual of a critical body of theory and evidence about implementation outcomes. We did find a lot of progress in the field. Again, recalling we were only looking at articles that had cited our paper, and we found that only 8% of the outcomes used a different terminology than we had proposed or used a different definition. Our free text coding did capture some alternative implementation outcome concepts, some of which we think could map on to terms. Evidence of delivery is probably actual adoption. Usefulness, I think, is a really promising, potentially new implementation outcome. Client efficacy in using the treatment is another concept that is worthy of some further attention. And timely initiation may actually map onto our service system outcomes of efficiency and timeliness. But we did find that no studies, okay, I hit the advance too soon. So we're going to go on. Yeah, now you've caught up with what my finger was doing on this slide, advancing. We also wanted to look at the relationships that were tested among implementation outcomes. Those of you who've read the 2011 paper may recall the hypothesis that we put forward that these outcomes are probably interrelated. In other words, actual adoption of an intervention or an implementation strategy may not occur if it is not viewed, if the intervention or strategy is not viewed as acceptable or feasible. So we posited that, for instance, perceived feasibility, acceptability, and adoption would be tightly related. And we hypothesized some other relationships that we expected and that we urged investigators to test. And we found that really only 21 studies, or 5%, did look at relationships among implementation outcomes. And the one that was most often examined was sustainability in relation to these outcomes listed here. We found that no other studies looked at cost with other implementation outcomes. In other words, we found no studies that looked at cost barriers in relation to adoption or sustainment. And this was a bit surprising to me. Then another question that we posed of articles in our scoping review, how were implementation outcomes examined in relation to service outcomes? In other words, how does attaining an implementation outcome actually impact our service delivery? And recall that the taxonomy for service outcomes came from work then being published by the Institute of Medicine, now the National Academies, and were such things as equity, effectiveness, timeliness, safety, and efficiency. So if we implement well, do we position our health service systems to be more effective, to be more efficient, to deliver more safe care, to achieve equity? And we believe that these hypotheses are conceptually grounded and quite rich for exploration. For instance, we think that service acceptability, feasibility, and perceived appropriateness should contribute to equity. And conversely, if we are delivering services that are not acceptable to a particular recipient group, participant group, if we are advocating for interventions that are not feasible, recall our urging for social distancing among COVID. How feasible was that for people who live in densely occupied apartment buildings with sharing one elevator, riding public transportation? So, we hypothesize in the 2023 paper that we should expect to see inequities when services are neither acceptable nor feasible nor deemed appropriate by the group we are working with to deliver services. Similarly, we hypothesize that effectiveness may have something to do with the feasibility, the fidelity, and the penetration of an intervention. In other words, if we only deliver it to 10% of the population in our service system, can we really expect to achieve aggregated measures of effectiveness? Probably not. And finally, that equitable access has something to do with the fidelity with which it's delivered, the penetration and the sustainment of evidence-based care. So we perceived and hoped to find empirically validated relationships between implementation outcomes and key service outcomes. And yet our sample of 400 studies contained only 4% of them looked at implementation outcomes and service outcomes. The implementation outcomes most likely to be addressed, most frequently addressed and linked or tested empirically in relation to service outcomes were cost, sustainability, feasibility, adoption, and acceptability. Now, we were quite disappointed to find that no studies of implementation outcomes in the 400 studies we looked at address the service outcomes of safety or equity, in spite of our hopes and our hypothesized conceptually valid links between these types of outcomes. And then what does successful implementation have to do with changing, improving people's health? We looked at the outcome, at the studies for tests of the effect of achieving implementation outcomes on client outcomes. And only 5% of the implementation outcome literature in our sample addressed this question. Which implementation outcomes were linked to client outcomes? Well, as we might expect, fidelity. There's a strong body of research in the field of psychology that looks at how well interventions are delivered with what fidelity in relation to their effectiveness in achieving client outcomes. Also, we found some looking at penetration, acceptability, very few looking at appropriateness, feasibility, adoption, sustainability, and none looking at cost. So the final question is, do we know how to attain implementation outcomes? This question would require research that treats an implementation outcome as a dependent variable in relation to some strategy tested for its ability to attain that implementation outcome. And in our sample of 400 studies, 56 studies did address this question. Which implementation outcomes were tested in relation to some strategy for their achievement? Mostly fidelity and acceptability. Some on adoption and feasibility, little on penetration, sustainability, appropriateness, and cost, leaving us pretty ill-equipped from an empirical perspective to know which strategies are effective in helping us achieve these implementation outcomes. So, where do we go from here? There's a lot of unfinished business. Unfinished business from our 2011 research agenda proposals. Recall that we challenged the field to advance the conceptualization and measurement of implementation outcomes by using consistent terminology, by reporting the referent for all implementation outcomes. By referent, we mean the level, the actor, the recipient. Who are we assessing acceptability? From whose perspective are we assessing acceptability? We know that interventions vary in their acceptance by providers. For instance, in behavioral health, particularly trauma therapy, the exposure aspects of treatment for trauma, it's very challenging to deliver, and it's also very challenging for the client participant. So we believe that these implementation outcomes are pertinent and can be measured from the referent of the provider, from the patient or the client, also perhaps from administrators who are making decisions about which interventions they want to support. What are they going to pay for? Do they perceive it as feasible, as appropriate for their service delivery system? We also have some unfinished business from the 2011 challenge to specify the level and methods of measurement. We had some real challenges coding because of lack of clarity with these factors. Also, we have more theory building. What is the salience of different implementation outcomes two different stakeholders. To whom does acceptability matter? I fear that for a long time, it's mattered to the payers and the clinicians and not to the people whom we expect to participate in and benefit from the interventions. We also have unfinished business with regard to theory building, understanding implementation outcomes by phases in the implementation process. Should these be pursued sequentially, or will attaining one of them facilitate another? And therefore there is some theory-based order to our selection of focus for a particular implementation outcomes pursuit. We encountered a sufficient number of coding challenges that it prompted us to write another paper with practical recommendations for improved implementation outcomes reporting. We decided to turn our frustration into more positively into some guidance, and our 6 recommendations paper actually contains an audit tool, which we encourage people to use prospectively when they're writing grant applications. We think this will help investigators think through how they plan to focus on a particular implementation outcome, how they plan to measure it, and how they plan to analyze the data. We also think that this will help the clarity of manuscript writing, and we encourage authors and journal article reviewers, journal editors to employ such a tool to help give feedback where articles could use better clarity in their description of the implementation outcomes. Clearly, we think we need more and more rigorous data sources. Implementation science as a field has heavily relied on self-report. And sometimes self-report is the best we have. But self-report, as we all know, is also subject to bias. So we encourage the exploration, the development, and the use of additional sources of data, such as surveys, interviews, actual observation, use of records. For instance, if intervention is adopted, scaled up, and sustained, there surely are accurate ways of capturing that in electronic records. Similarly, checklists are often used in fidelity monitoring, and implementation cost can best be assessed and captured through time logs and through budget data. So self-report has served us well to date. It's time that we explore and use additional sources and more rigorous ways of measuring implementation outcomes. And this table just highlights some of the ways in which the unit of analysis can vary, and that we can analyze data from multiple perspectives, as well as the salience by phase. So I think the greatest challenge that lies ahead, and the area with the most unfinished business, involves testing relationships. We need to examine with the best methodologies that we can how implementation outcomes relate to one another. Does the acceptability of an intervention or a strategy improve the reach and the penetration of its delivery? Does the feasibility of using an intervention or a strategy, does that help us sustain its use? What strategies are effective to attaining implementation outcomes? And please recall, in my early slides, I emphasized that outcomes are states to be attained. If something isn't acceptable, we don't just say, too bad. We adapt it, we modify it, we gain user perspective to try to reshape an intervention or an implementation strategy to make it more acceptable. Well, if that's our approach, we really need to know what strategies are effective in attaining these implementation outcomes. And then I think, our field has been looking internally, importantly. Any new field needs to get its act together. We need to have language, we need to have terminology, we need to have shared concepts. So I would say that implementation outcome has been working, the field has been very active in building up the body of what constitutes implementation research and the methods that we employ. I think it's time, as we continue that work, to begin to look outward beyond the implementation process and begin to tackle the question of what is the effect of successful implementation? How does implementation success help us get to equity? How can implementation outcomes inform the safety of our health services? And most importantly, can we document that successful implementation actually helps individual clients served by our systems and the communities in which we deliver our services? So in conclusion, some key takeaway points. We found lots of description. We found hefty use of qualitative and mixed method assessments. And we found that implementation outcomes are being investigated in a wide array of settings. However, we found little evidence that interrelationships are being empirically examined. Do we know what strategies are useful in attaining implementation outcomes? And do we know their effect on service delivery and client outcomes? So we need to measure implementation outcomes distinct from other types of outcomes. We need research to identify strategies for their attainment, and we need to know how successful implementation, how that matters. The implementation outcomes taxonomy should not serve merely as a checklist. Outcomes to be measured at one point in time, describing the process. And once we've measured it, we're done. Instead, we need to tackle these important conceptual and empirical issues so that we know how implementation outcomes matter and how we achieve them. So we urge greater testing, prioritizing testing on implementation interrelationships, leveraging various methodologies. Now we have a much broader and more robust, more complex toolkit of designs and measures. Let's harness those to help answer these important questions about implementation outcomes. Thank you so much for listening. I look forward to hearing your questions because we all are continuing to learn about this topic.
Thank you, Dr. Proctor. That was really wonderful, thought-provoking, timely, and thank you. There's time for questions, and there are several, so I will try to package them into some themes and send them your way. So let's start with the first one here, which is how might context, particularly outer context, beyond organizational contextual factors, impact implementation outcomes?
Excellent, excellent question, and an area that I encourage more research. Clearly, some of the implementation outcomes may be primarily driven by contextual factors beyond the organization. Policies often determine how cost feasible an intervention is, how sustainable. we see priorities changing. Policies are sometimes criticized as tackling the new bright shiny object, and changes in the outer context often strip away the resources, even the momentum for pursuing improvements in areas that are no longer the issue of the day. Certainly, the community access, structural barriers, transportation, location, hours of clinic operation, all of these affect the feasibility of delivering. Certainly the workforce, are we training people correctly around priority interventions? And how do these factors either support or threaten our ability to achieve intervention, feasibility, adoption, and sustainment, and cost in particular?
It's great. There are several questions about costs, Dr. Proctor, so I'll try to get them all together one after the other. So regarding costs, knowing the uniqueness of implementation strategies, are there guidelines to employ around costs? And then it says sustainability, feasibility, fidelity, etc. I'm not sure that the question is clear to me, but perhaps you can shed some light on it.
Well, certainly, I welcome the questions about cost, and I encourage much more and better work around cost. When I first began to wrap my head around how implementation outcomes operate, I viewed them as, if we don't achieve them, party's over, we're going nowhere. And if interventions are simply too expensive to deliver, then cost becomes a barrier. And the implementation research, the implementation practice challenges become, how do we make them cost possible? So cost is a barrier, and we want to achieve cost possible situations. So there are a number of issues surrounding cost in the implementation literature and in the implementation outcomes literature. First of all, I applaud the editors of Implementation Science and Implementation Research and Practice for supporting a special collection or a special issue, an online rolling special issue on costs around implementation. Those articles, which you can find by searching either journal or searching the special issue on cost, give a lot of insights into how we can capture and study cost factors. That is really important. And I've heard, what is the role of cost? How much of a barrier is cost? How much of it is a facilitator of cost feasibility? I've heard everything from some people cynically say, well, anything can get implemented, we just have to pay for it. And that lack of payment is always, the big barrier. No doubt, lack of payment is a big barrier. And linking it back to the prior question, that is often a function of formularies, of payer decisions, of preferred profiling of different interventions in a registry of what clinicians can get reimbursed for delivering. On the other hand, I call out the work of my colleague Douglas Luke at Washington University's Center for Public Health Systems Science. Their team has really dived deeply into the sustainability challenge, and they found that financial support is important, but it is not the only or sometimes the most critical factor. So we, short answer, there's a growing, thankfully, body of literature around cost, And I encourage further investigation using some of the recent methodologies to capture cost and some of the conceptual frameworks that help us know how to think about cost, making it feasible and reducing the barrier of payment.
Yeah, no, that's really interesting and also intricately related to equity, especially when interventions are being implemented in under-resourced settings. Costs of implementing strategies becomes so important. And there are a couple of questions here about equity, which I'll bring up here, which is, could you speak a little more about how you conceptualize possible measures of equity, particularly among those studies that only include one implementation strategy, meaning that there is no comparison of equity, perhaps?
Well, latching onto that last point, it's critically important that we have studies that pit strategies against each other in robust tests to see which are more effective in achieving any of the implementation outcomes and the service system outcomes, such as equity. The measurement of equity, there are experts who can speak better to that than I can. I hearken back to the behavioral model of health service delivery by Anderson back in the day of health services research. Maria may be the only one among us who has been at this long enough to know that model. But inequity is defined in that model as the delivery and receipt of services as a function of anything but need. So need-driven service delivery promises to be equitable. Everyone with a need should have access to and quality delivery of an intervention. So I take us back to need, and too often opportunity, social barriers get in the way, and I long for a day when we can deliver the services that are needed and people can receive the services that they need.
Yeah, that's a great point, and such a challenge in the field. Appreciate that. What could be the explanation of having few studies, very few studies addressing equity, safety, and cost?
No, I'm not sure that that we as implementation researchers have adequately enlarged our focus beyond the implementation process to the effects of successful implementation. I think, you know, we have people pursuing better understanding, testing, and ways to achieve equity that are within implementation science, but I have seen very little use of or very little attention to strategies, implementation strategies that can help us achieve equity. And more importantly, I think it's really important to not skip over the proximal implementation outcomes that are likely related to equitable service delivery, such as I highlighted with, you know, unacceptable services, services that are not feasible, services that people refuse, etc.
Right. There's also here a question about fidelity. Can you comment on the importance of balancing fidelity and flexibility in implementation? How do we walk the line, making sure we are true to interventions/strategies, but flexible and responsive to organizational needs?
Yeah, really, really excellent question. And it reminds me of a talk that David Chambers and I were giving a talk at a conference for a particular professional body. And it was kind of a guild meeting. And he was talking about advocating for adapting interventions and adapting strategies so that they have a better fit. Many of you probably read his article that includes or references to the puzzle piece. How well does the puzzle piece fit? How well does the intervention, how well does the strategy fit into the context? And at the end of his talk, a couple of people ran to the front and asked the question, do you mean you expect my intervention to be tinkered with? So I think intervention developers and those who test interventions, they've done so laboriously. They've done so carefully. They have included what they believe and their work suggests are critical elements of the intervention. And therefore we experience the threat to tinkering with that in any way, shape, or form. And yet we know that our lock, stock packaging or delivery approaches often get in the way. I worked with a treatment developer who was working with parents to deliver an intervention that required 18 weekly sessions. And I was skeptical. It soon became very clear that very few parents could come to a weekly meeting for 18 consecutive weeks. And I think the reality is people will adapt their participation and they will pull away from, they won't fully partake of interventions that are not feasible, that are packaged in a way that they can't participate in unless we are willing to adapt and modify the intervention to better fit their needs. So, I often think of, this isn't very scientific, but the old limbo game. How low can we go? How much can we strip away to make it acceptable and feasible and implementable without stripping away the essential? And I think that is work for treatment developers to tackle and for implementation scientists to help partner with treatment developers around strategies to incorporate user feedback so that we know which elements of the intervention or its delivery are posing the barrier.
Yeah, that's really very informative and making the case for bringing implementation science so much more earlier in the process of developing the interventions, thinking about the need for flexibility and adaptation when it hits the real world, so to speak. So I think that's fantastic. We have a lot more questions, and I don't think we have enough time now to tackle them. I'm happy to share those questions with you, Dr. Proctor, but I'm going to save them because the questions are really good here. Again, I want to thank you for just a phenomenal, thought-provoking presentation, and I want to also thank all the attendees in engaging with all of these different questions, and I wish we could have gotten to all of them.
Yes, I welcome seeing the questions. My thinking continues to evolve. So I welcome hearing the questions. I want to thank everyone. I want to thank you all for the opportunity to share these ideas with you. And I look forward to the furtherance of our work on implementation outcomes by so many researchers in your audience.
Thank you.
Thanks so much, Dr. Proctor.